Our next speaker, Dr. Charlotte DiStefano. Charlotte was also the last 3 days down in Redondo Beach with our families, doing assessments along with Rajuta and the UCLA team. So met a lot of our kiddos, and she's going to and has worked with them in the clinic for a long time as well. So she's going to talk to us about understanding abilities in minimally verbal children and considerations for behavioural assessments. Thanks, Charlotte.
All right, so as Guy said, I work in the Geste Lab. I've started working with kids with Dup15q syndrome due to Shefali's interest in that group a couple years ago. I'm a clinical psychologist. My background is specializing in language and communication development in kids with ASD. I like to jokingly say that I study language in kids who don't talk because I specialize in the minimally verbal group of kids. And so when Dr. Geste started working with Dup15q kids, it was a great fit for me because a lot of kids with Dup15q are minimally verbal and fit that profile. And so I really started with the Orlando Family Conference 2 years ago. I went with our group there, met a bunch of families, did a bunch of assessments. As Guy said, got to see them again this year. A lot of families I got to see who had come back from the Orlando conference, got to see how their kids had changed, which was really fun. So I'm going to be talking a bit about how we assess abilities in these kids, how we think about autism and social communication, and how we can define those things in groups of kids who have limited language. And then with the Dup15q population, the additional difficulties that are presented by their motor impairments and how that impacts our abilities to get good estimates of their skills in other domains. So a quick background for anyone who's not super familiar with this. I'm not sure why it's showing up like that, but ASD, which should be the first bullet point, is categorized under neurodevelopmental disorders in the DSM, along with intellectual disability, global developmental delay, ADHD, communication disorders, motor disorders. Those are all now in the neurodevelopmental disorders category. In terms of how we actually measure and define ASD, it's defined by 2 core areas now. We don't have 3 core areas anymore. The first is impairments in social communication skills, and the second is the presence of restricted and repetitive patterns of behavior. And then we can further define that in terms of a child's expressive language skill and the level of support that's needed, which we can think of as kind of a severity level. And what this really means, what we're looking for when we're making a diagnosis of ASD, are these impairments in things like social emotional reciprocity, building relationships, and then in terms of repetitive behaviors, we see a lot of insistence on sameness, restricted interests, unusual sensory interests, and these are the type of behaviors that we're looking for. The important thing to think about in ASD in general, but I think especially in things like Dup15q syndrome, is that ASD is a diagnosis that is made based on behavioral observations, behaviors that parents report to us, behaviors that we observe in the children. It's not a diagnosis that is based on etiology or underlying neurobiology, and so there are a lot of different ways that you can come to have ASD-type impairments. And so we see considerable variability in the way these kids present, what their developmental trajectories are, how they're going to respond to intervention, and then the outcomes. And something that I was really struck by once I started working with kids with Dup15q syndrome is although these kids often meet criteria for ASD because it's just a set of behaviors that we're looking for in order to make that diagnosis, although they meet criteria, I was seeing some qualitative differences in these kids that I felt like differed from my experience with minimally verbal kids with non-syndromic autism. And so I got really interested in trying to think about how to quantify those differences and what those differences might be and how that can help us understand the skill development in Dup15q syndrome. So just want to quickly explain to you guys what the ADOS is, if anyone's not familiar with it, because we're going to talk about it a lot. This is one of the instruments that is often used to diagnose ASD. It's not in and of itself an ASD diagnosis, but it's used clinically as part of a diagnosis. And in research, we often use it to validate a diagnosis and make sure that child is showing the symptoms we expect. So it's a set of standardized materials that we use to set up a variety of social and communication situations. The activities and materials vary depending on the child's age and expressive language level. And then during those situations that we're setting up, we're probing for relevant behaviors and skills that are associated with ASD. And this can be discrete skills, things like responding to a social smile, responding when someone calls your name, or these can be skills that we're looking for across the course of the ADOS, like well-integrated, coordinated eye contact. And that's going to be relevant a few slides later when I'm talking about some of the specific patterns that we see. So then you score all these items at the end of the ADOS. You add up a subset of those items, and if the child has more than a certain number of points, we say that child meets cutoff levels for ASD. So it's kind of an over-under. You're either above that threshold or you're under that threshold. And then additionally, this is going to be important later on, we can generate a severity score. So for everyone who's above that threshold of ASD, we can then further define sort of how far above that threshold they got. So all of that is to say that you can have a variety of different strengths and deficits and still end up getting over that threshold for ASD on the ADOS. There are a lot of different ways to add up that number of points and meet the threshold for an ASD diagnosis. It doesn't mean that we're seeing the same patterns of behavior in every child who meets that threshold. So with that in mind, we were interested in looking at how there might be distinct developmental profiles in kids with Dup15q syndrome compared with kids with non-syndromic autism. So this was a paper that we published last year, and we really wanted to take a fine-grained look at not just saying, okay, these kids with Dup15q meet thresholds for autism, but if we look a little more deeply, and we have a matched sample of kids with non-syndromic ASD, do we see the exact same patterns? Can we find any differences? So we had 13 kids with Dup15q who participated in this study. They came here to UCLA. And then we matched them with 13 kids with ASD, and these were matched on both chronological and mental age. And we had kids who were about 2 to 12 years old, so a pretty big age range. And Rajutha highlighted a bit of this data, so I'm going to go quickly through it. Obviously, motor skills are different. This is the same graph that she showed earlier. We don't see differences in verbal and nonverbal developmental quotient between our groups, which is good because that's what we matched them on. But we do see differences in their fine and gross motor skills. Kids with Dup15q are having a much harder time with those skills compared to the non-syndromic ASD kids. And as we think about measurement in this population, I just want to stop and point out that the nonverbal developmental quotient here, you can see the blue box, although the means are not different, it does look qualitatively like the Dup15q group is doing a little bit worse than the ASD group. That domain score, the nonverbal developmental quotient, includes fine motor. So when we think about how we assess these kids, if you don't have language and you can't express yourself linguistically, a lot of our developmental and cognitive assessments then rely on performance tasks to measure your abilities, and those are typically going to tap into motor skills. So the Mullen, which you've heard mentioned a few times, explicitly uses the fine motor subscale as part of the nonverbal score. But even when we get up to higher to cognitive assessments for kids with some higher level abilities. For example, on the DOS, which I'll talk about later, part of the nonverbal subscales are made up of two subscales that tap very heavily into motor skills. You have to copy patterns, and you have to arrange blocks to copy a pattern, and that portion is timed. And so obviously then your nonverbal IQ is going to take a big hit if your fine motor skills are impaired. So something to think about as we think about measuring skills in these kids. And then, as Rajutha already mentioned, we saw really high correlations across the different skill domains in kids with Duke 15Q, which we did not see in the ASD group. And that's pretty typical of kids with ASD. We see abilities that are kind of separated from each other. You might have really strong abilities in one area and low abilities in another area. They kind of separate out. But in Duke 15Q, we are seeing a lot more consistency. And particularly, we saw that motor skills were very highly associated with every domain that we measured, which we did not see in our kids with ASD. So Rajutha already talked about that a lot, but it really suggested to me this idea that motor skills might be influencing and constraining social communication skills in a way that it may not be the case in our ASD participants. So I mentioned to you that on the ADOS we can generate a severity score. So although all of our participants in, of course, the ASD group and the Duke 15Q group met that cutoff level for ASD, our Duke 15Q participants as a group had a slightly lower severity score than the ASD group, about 2 points lower on a 10-point scale. And so we wanted to look at the individual ADOS items and see if we could figure out where that difference was coming from. These kids were obviously not scoring quite as high, high means more impairment, not scoring quite as high somewhere because their severity scores were coming out a little bit lower. So we looked specifically at the reciprocal social interaction items. If you have detailed questions about these, I'm happy to answer them, but I'm just going to kind of go quickly through it. We looked at the scores on the reciprocal social interaction items, and the pattern that emerged I found really interesting. The kids with Duke 15Q syndrome had significantly better scores on 2 of the items, which were responsive social smile and facial expressions directed to others. And these items were interesting to me because if I think about how an ADOS is conducted and what the child has to do in order to earn these scores, these are both fairly discrete items. Responsive social smile, I get right next to the child's face. It's easy for them to see me. I say, hi, you're wearing such a cute shirt, something like that. I smile at them and see if they have that social smile response to me, if they smile back. So motorically, it's quite easy. I'm right there looking at them, and they only have to do it once to earn the score on that item. Same thing with facial expressions. That's a code that goes throughout the ADOS, but still those are discrete opportunities. If they shift their gaze and smile at me, or they're scared of the balloon and they make an afraid face and direct that to me, then they're earning credit for that facial expression item. Versus an item like eye contact, everyone had an impaired eye contact score. That item looks at the quality of eye contact, the child's ability to use eye contact to regulate social interaction across the course of the ADOS. So even if you have periods of great eye contact, great integration with other social behaviors, if there are times where that's absent, then you're not going to get credit on that item. So I'm reading quite a bit into this, but to me that suggested that maybe these children do have more intact social motivation than we're giving them credit for, and we can see it in those very clear discrete opportunities where there are not a lot of motor demands and they don't have to sustain the behaviors over a period of time. But if we're using assessments that are measuring things like eye contact over an entire 45-minute interaction, then we may be losing our ability to detect that they are using those appropriate social behaviors at certain opportunities. And I'm going to show you some videos in a few minutes for you to see some examples of that. An interesting contrast, just to highlight, Dr. Geste's lab also studies kids with TSC. We did a similar analysis. This graph here in the purple and orange is a similar ADOS item level analysis looking at kids with TSC versus non-syndromic ASD. And you can see that the lines are almost perfectly on top of each other, which is really in stark contrast to our Duke 15Q kids where, although only a couple of them emerged as significant statistically, there's a pretty different pattern there. So kids with Duke 15Q are showing some more intact skills on a variety of items. So that was sort of my first foray into studying kids with DUT15Q syndrome. And as I said, I was really struck by the fact that even though all of our participants met the ADOS criteria for ASD, it seemed like there were some qualitative differences, which we were able to quantify a little bit. And they showed us that they had some relative strength in social interest and social motivation. They had marked impairment in motor skills and this relationship between motor skills and skills across other domains. So obviously, Rajutha went much more into that. I'm now going to go a little more in depth into how else we can quantify social motivation, joint attention, engagement, and some measures to think about moving forward that I think might give us a little bit more of a fine-grained understanding of what's happening in these kids. So if we think about expressive language, a lot of different skills have to come online in order for you to develop expressive language, right? So being minimally verbal or nonverbal does not necessarily mean that you have a deficit in social motivation or social interest. There are all sorts of deficits that can contribute to not developing spoken language. We talked a lot about motor skills. You obviously need to have some basic sensory perception abilities. You need some level of cognition and receptive language in order to develop spoken language. There are underlying learning mechanisms. And then there are these social skills like joint attention, imitation, being able to engage with another person. And we know that that is one of the core deficits in kids with ASD. So joint attention is the active coordination or shared attention between a partner and an object. So right now, we are all jointly attending to these slides, right? All of our attention is here. If I point to that picture, you guys know that my words are associated with that picture now that I'm talking about, of a cutie pie named Parker. He's a wonderful kid. These early joint attention behaviors, which come online well before spoken language does, we see this in infants under a year old, they predict language development across the board. Kids with ASD, typically developing kids, kids with language delay. And then specifically, we can translate that to this idea of joint engagement, which I'm going to talk about a little bit more, which are periods of time where a child and a communication partner are jointly engaged in some sort of ongoing activity, and there are joint attention signals going back and forth between those two people. And those periods of joint engagement also seem to be really, really fundamental for learning. That's the context in which kids learn things, right? You learn language because you're jointly engaged with your caregiver talking about your bottle, and you're looking at the bottle and you're looking at your caregiver and you're hearing your caregiver say the word bottle and you're mapping that to the object. So those periods of joint engagement are really, really fundamental for learning all these social communication skills. So I'm going to show you a few videos now, and with that background, these are kids who we saw at the conference this week. With that background, when you watch these videos, I want you to think about what sorts of social communication behaviors you're seeing from these kids and how their motor skills especially might be impacting their abilities to jointly engage, to participate in those interactions. So this is our first kiddo. She is 4 years old. These are her age equivalents on a variety of different domains. So you'll see in the video her motor skills look pretty good. But on an assessment, she's still only about 50% of where she should be. Her age equivalent on motor skills is about 2 years old. Her visual reception skills are also around 2 years old, and then her language is actually her strongest skill. She came out at an age equivalent of about 30 months. Hoppity hop, bunny. Look, we have bubbles. This is the ADOS. You want his ears to touch the bubbles?
Yes. He's blowing the bubbles. The blow bunny.
Hello, bunny.
Ah, good job, bunny.
So we see some really, really nice social communication skills from her and some very clear social interest. She still managed to meet cutoffs for ASD on the ADOS. She had enough unusual behaviors. She showed a lot of repetitive and restricted behaviors. She wouldn't put the bunny down. The bunny had been from an earlier task, and she had to hold it for the whole rest of the ADOS and became very distressed if I tried to remove it, which is something we score on the ADOS. And her language, she was directing to me and using, but it was a little odd, a little repetitive. She would repeat the sound, the initial consonant of the word over and over before she'd move into the rest of the word. But she would look at me with clear social intent, make really nice eye contact. Of course, there were times she wasn't making nice eye contact, so she didn't get a good score on that item, even though some of it was great. She showed some pretend play, right? She was pretending that the bunny was blowing the bubbles, and she made that blow gesture, which she gets credit for on the ADOS. And so this is a kiddo who, I feel like our ADOS measurement of her social communication skills is probably pretty accurate. She's able to participate in the activities. She is able to navigate the environment, get over to the bubbles if she wants to see them, quickly shift her gaze to me, back to the bubbles, manipulate the bunny. So she can really show me all of the social intent that she has because she has sufficient motor skills to do that. Here's another kiddo. He's 7 years old. You can see from his age equivalents, again, he's somewhere around half of where he should be developmentally. This is a kid who could not do the motor tasks at all on our cognitive assessment, so they're considered the spatial subdomain on this assessment, but they're the copying and block design that I mentioned earlier, and he just couldn't even attempt the first item because his fine motor skills wouldn't let him do that. And in this example, what I want you to notice is that he starts out with a lot of communicative intent, and then both I and his mom can't understand what he's saying, and he gives up and we move on. Okay, let me know when you need more pieces.
Oh, I have 5 minutes.
You have 5 minutes until you finish. It's his way of telling me he didn't want to be there. So I look to mom, she doesn't know either.
I didn't hear what you said. We did the puzzle.
So if we think about that kid's experience in social communication interactions, right? He started out with some good communicative intent. He picked his head up and looked at me and made eye contact, and he started out with saying a sentence, I have 5 more minutes, which is a bit of an unusual way to say I'm done with this, but I got the idea. And then he continued on and said something else, and who knows, we might have been able to have a reciprocal exchange, but I couldn't understand what he said. His mom couldn't understand what he said. And this is a kid who had pretty low muscle tone overall, even though he could walk and run just fine. He spent most of the ADOS laying on the floor on his stomach. That was his sort of preferred way of sitting. I think the core stability was hard for him, and it was hard to sort of maintain sitting for 45 minutes. So as he moves through the world, his ability to interact with people is going to be impacted by his motor skills perhaps constraining his ability to say words clearly and be understood. And then later on in the ADOS, once he was laying on his stomach, there was a lot less of shifting his eyes up to me and communicating that way because, of course, once you're laying on your stomach, it's harder to pick your head up and look at someone who's sitting above you. So for this kid, we start to see that interaction there where he certainly is presenting now with a social communication impairment, but I wonder developmentally what the effect is of having those limited motor skills early on in developing that phenotype. One last video. This is a kid who shows a lot more impairment in motor skills, and of course on a standardized assessment of cognition shows much lower skills. And again, if we look for very subtle signs of social interest, once she's in an easy physical position where she can access my face easily, how quickly she goes to looking at me and using gaze to communicate social intention, but then how difficult it is for her to get her body into a place where she can do that. I think you'll really see the impact here.
You need to chase them? Yeah. Well, you want to taste the bubbles. They're not going to taste good. I swear to you, they will not. Here they go.
So she's looking right at me. She's smiling here. She's clearly engaged. And it's a lot easier for her now because we're face to face, unlike we were with the bubbles. And here she's going to shift her gaze to the balloon and then shift it back to me, which is one of the things that we look for on the ADOS. But if you think about how much effort that takes for her, it's not surprising, again, that over the course of the ADOS, we're going to observe relatively impaired social communication skills, even though in these discrete moments, she's able to use the resources that she has, which are gaze and facial expression, to express those things. So now I'm just going to show you a couple things that we're sort of thinking about moving forward for how we might better be able to capture these things. There's something called the Early Social Communication Scales, which is not a normed assessment, but it is a structured observation measure where we probe for social communication behaviors and we look for initiating and responding to behaviors, behaviors used for requesting or joint attention, social interaction. And I was curious to see, there are 2 responding to joint attention conditions on this assessment. One where I point to pictures on a wall, so the distal points, and say, Kelsey, Kelsey, look, and look to see if she shifts her gaze to where I'm pointing. And the other is a proximal pointing condition where there's a book on the table, and I point to one of the pictures on the opposite page to see if she shifts her gaze. So obviously, motor-wise, it's a lot easier to shift your gaze in the proximal condition than to get up and look where I'm pointing on the wall. So this is just a bit exploratory, but we coded from that original study that I presented, the 10 kids who had this assessment, to look at their data. And you can see that all but one of them responded in the proximal pointing condition, where it was pretty easy to just shift their gaze. It was right there on the table. But only about half of them were able to respond in the distal pointing condition. And we do it 8 times, and most of these kids who responded only responded once or twice out of the 8 times. So I think moving forward, this suggests to me that this might be a good way to try to pull some of those pieces apart and look at these easier discrete social communication skills to see what's there. The last thing I'll highlight is that at an even more subjective level, we can just code how long a child spends engaged with another person, how long they're able to maintain that reciprocal engagement. And I'll answer questions about this if you want, but in the interest of time, I'm just going to say that we can code times that a child is jointly engaged with me, with a toy, doing an activity, versus times where the child's not engaged, they're not engaged with me at all, or maybe they're just engaged by themselves with an object. So this is data from 3 of our kids, again, from our first study that we did some pilot intervention with, an engagement-focused, play-based intervention. We saw them for 16 sessions over 2 months. And we just coded the amount of time they were able to jointly engage with the interventionist and some sort of play activity, and how that changed from the first session to the last session. And so blue is the first session, yellow is the last session, and you can see that all these kids more than doubled the amount of time that they spent engaged in those reciprocal activities, which is, of course, the context for learning. And this sort of really fine-grained look at what's changing in these kids, I think is important to think about as we think about intervention targets. I don't think any of these kids changed on a standardized assessment, right? Their ADOS score probably didn't change in 2 months. I don't think that their developmental quotient changed in 2 months. But if they're spending twice as much time now engaged in the learning context in their environment, we might be laying the foundation for them to build more skills over time. So that's the end. I'm happy to answer questions. Hopefully you can see that, although social communication impairment is certainly common in Duke 15Q kids, we do see this motivation to interact, which seems to be impacted by difficulty sustaining behaviors and the motor impacts. So our choice of instruments is going to be really important for how we detect that variability and change over time. Their motor impairment certainly affects their performance across a variety of instruments, so we need to take that into account when we're thinking about how to use those scores. And as Rajitha talked about, I think that motor skills are going to be an incredibly important avenue of intervention for these kids, not just for the motor skills themselves, but for all the other areas of learning that are going to be influenced by their ability to motorically participate in those activities. And I would love to follow some of these kids longitudinally so that we can see the developmental course of their motor and social skills and how these are developing in tandem over time. So that's it. Thank you very much. Thank you so much to all of our families who participated. They are the best, and our whole lab.